Let me ask you a specific question, James. So what facilities do we have in place to meet these needs? And could you describe the innovative new arrangements in Bristol with collaboration with public, voluntary and community sector providers, the bit we started introducing earlier?
So I'm sure many people in the audience will be aware that Bristol Clinical Commissioning Group, which came into existence around 18 months ago, took a very bold and ambitious step, a very progressive step, to basically deconstruct the way that we think about community mental health provision, to take the financial spend that was going on into community mental health teams and to think again how that could be divided up in order to meet the needs of our needs in Bristol. We have a very diverse city. We have emergent populations who are not being well served. Marvin's point was well made. Which Bristol? I don't think any of us would say that the audience here is representative of our city, and certainly isn't representative of the people who need mental health service. So all of this comes on the backdrop of the last 20 years of mental health provision, which has seen a move away from asylums. So Barrow Hospital, many of you will be familiar with, the move to community mental health teams in the 1980s. Care in the community was the phrase that was used at that time. And that was about, it was the first step of bringing mental health problems closer to home and closer to primary care, so GPs, but also closer to communities. We've not really moved on significantly over the last 20 years in terms of the way mental health services are organised. We have largely based it on the structure of a team with a psychiatrist, with nurses, with some occupational therapists, psychologists, and there are limits to what that team can provide. And that was certainly the case in Bristol when the Clinical Commissioning Group decided to go to the market and to try and stimulate the market. Different people have different views on the health and social care bill that our government pushed through. But the outcome of that was that it was possible to go to the marketplace to look for private providers, NHS providers, voluntary sector providers. Anybody was eligible to deliver services. The specification that the Clinical Commissioning Group came up with was to divide or restructure mental health provision into 6 key areas or 6 key pathways. And these can be broadly thought of as the crisis services, the recovery teams, assessment and recovery teams, which can be thought of as being similar to what existed before. But in addition, they took out dementia care to have a separate pathway, a community rehabilitation approach, employment services, an assertive engagement service, and a community access service. And all of those can be, if you want to read about that, then I'd suggest you go to the Bristol Mental Health website, and I don't want to labour those structures in too much detail. The outcome of all of that was a very large amount of activity that the CCG had to coordinate as different bids came in from different providers with a different model of how they would deliver these services. And we now have a collaboration or network of 18 different organisations that are going to be delivering services in the city. That's quite remarkable. That's all going to be held together through a coordination function which is called system leadership. And that is a means, if you like, of knitting together all of the pathways and the clinical activity of the different organisations. We, I work for an NHS trust, and we acknowledged in all of this that there were things we could be doing significantly better, and that certainly there were things as an NHS trust that we couldn't achieve on our own. Some of that is about accessing the diverse communities in our city. It's about knowing how to communicate with people, with communities that don't necessarily have a voice, or that may have particular views on mental health provision, or in fact not really wanting to acknowledge mental health as a problem. So we formed a partnership with 9 voluntary and community sector organisations who, between us, have over 240 years of experience in the city. And Carol's organisation, Missing Link, is one of those key community sector providers.
So how significantly do you think this is a real conceptual shift from anything that's happened before? Because that's what one of the reasons that actually it was Primary Care Trust who initiated the recommissioning, because service users were saying this isn't meeting our needs. So do you think conceptually, well, it's in theory and in practice, it's making that leap that we want to make?
Absolutely. I think conceptually it definitely is. I think that it was a very brave and ambitious step. It's a very progressive model. The key features of the model that the clinical commissioning group have described are for a more responsive service, so people struggling to get in, a no wrong door policy, so that it's not about being turned away, it's about being helped and led to where you need to be in the system. For it to be much more user-focused and also primary care focused. So it's about supporting and enabling GPs to deliver better mental health, but also to have the confidence and awareness of what's around in the city.
Okay.
The other thing I just wanted to drop in, Tara, was a very, very strong theme that runs through this, which is about having users at the heart, service users at the heart. The message that came out of the consultation was that service users felt they were on the outside of services and they were being delivered to them, not with them. And that is a very fundamental shift that this model helps us to address. So we've got a progressive medical and social model. We're going to be behaving much more out there rather than in here, in-house. Much more responsive with access for harder to reach communities, very user-focused, elevating the service user to a director role actually within the system.